Good afternoon, everyone, and thank you for joining us for today's webinar, How Coverage Exclusions in Marketplace Plans Compromise Women's Health and Economic Security. We have just a few technical notes before we begin the presentation. First, all lines will be on mute during today's webinar. We will be taking questions after our experts are finished with their presentations, but you can submit questions throughout the webinar by entering it into the designated area on your control panel and hitting send. I'd also like to note that we'll be recording today's webinar, and you'll receive a link to the recording as well as to the PowerPoint slides within the next few days. And at this point, I'd like to turn the floor over to Janelle George, who is the Director of Federal Reproductive Rights and Health at the National Women's Law Center. Janelle, take it away.
Thanks, Amanda, and thanks so much, everyone, for logging into today's webinar. We'll focus today on a report that was recently issued by the National Women's Law Center and supported by the Commonwealth Fund entitled Women's Health Coverage Since the ACA, Improvements for Most, but Ensure Exclusions Put Many at Risk. And we hope that many of you logging in today have had the chance to read over the report and how it details exclusion that women are still experiencing on their health plans since the ACA's implementation. Today we'll hear from 3 expert panelists who will discuss these exclusions more in detail, and we really hope to leave time for questions so that we really have an informative discussion about plan exclusions that specifically have a negative impact on women's access to health care, and also to discuss recommendations for identifying and addressing these exclusions. First, I would like to just give some background on our 3 experts who will be speaking with us today, and then we will hear from those experts. The first panelist is a co-author of the report, Danya Polanker. She recently served as Senior Counsel for Health and Reproductive Rights with the National Women's Law Center, and she's an expert on the private insurance provisions of the ACA and has dedicated her work to expanding access to quality, affordable health care for low-income families. She also has previously served as Associate Director of Health Policy for the Health Services Division and Deputy Administrator of the Health Benefit Program at the Service Employees International Union, or SEIU. Ms. Polanker has a law degree from Georgetown University and a master's in public policy from the Kennedy School of Government at Harvard University and a BA from Middlebury College in Middlebury, Vermont. She will be discussing the 3 primary exclusions that were covered in the report, as well as some recommendations for addressing these exclusions that were also detailed in the report. Following Ms. Polanker's presentation, we'll hear from Dr. Sue Friedman. In 1996, Dr. Friedman was diagnosed with breast cancer at the age of 33. At that time, she was unaware of familiar risk factors for hereditary cancer. But after reading an article about hereditary breast cancer after completion of her treatment, she realized that she had several indicators for a mutation. She founded the organization Facing Our Risk of Cancer Empowered, or FORCE, in 1999 to fill the void for individuals and families with hereditary cancer and to help them advocate for themselves. She has over 18 years of experience assessing and addressing the unique needs of individuals and families affected by hereditary cancers, including breast and ovarian cancers. She also serves as a patient expert on several national panels, including the National Cancer Institute, the National Comprehensive Cancer Network, and the Centers for Disease Control and Prevention. She will be discussing the impact of exclusion on women who are at particularly high risk for cancer. And finally, we'll hear from Tim Clement. Mr. Clement is a policy director of the Parity Track Project, which is a joint project of the Kennedy Forum and the Scattergood Foundation. He analyzes legislative, regulatory, and statutory policy related to behavioral health, particularly policy pertaining to mental health and addiction parity. And I think many will be surprised at how the report details some exclusions, particularly related to mental health parity issues. Tim has a master's degree from the Drexel University School of Public Health with a concentration in health policy, and he will discuss mental health exclusions impacting women. So why don't we start with Danya Polanker, who again is one of the co-authors of the report. Thank you, and Danya?
Thank you, Janelle. So as Janelle said, I'm going to give an overview of the report and in the report we talked about 6 exclusions we found. And I'm going to talk about the 3 of the exclusions in a little bit more detail that the other speakers on the webinar will not be speaking about. So on the next slide, we'll start with just an overview. So I'm going to start with the methodology so people understand what we actually addressed in this brief, some of the key findings, and I then want to talk about the policy recommendations. And I do want to note that the policy recommendations we addressed in this brief were really general. I know some of the other 2 speakers may address some very specific policy recommendations that really are more specific to the issues they're talking about, but we were sort of talking more broadly about the problems of exclusions that women may not be aware of, or exclusions that may on a large scale create gaps. So the next slide talks through the methodology. And to start, this project really came out of another paper that the National Women's Law Center wrote and published in 2015, which looked at how health insurance plans on the marketplaces violated the Affordable Care Act. And when I and other staff at the National Women's Law Center was looking through those materials, things were jumping out at us as problematic, but not explicitly unallowed. And so that was where the idea for this came from. It was funded and published by the Commonwealth Fund, as Janelle mentioned, and we reviewed plan documents from 109 insurers in 16 states, and they were 2014 and or 2015. Some states were both plans. And just a little bit about the insurers so people know is we did, one in what we think of as a carrier may have been counted multiple times because we counted each carrier different in a different state. We counted them different for a multi-state plan than a regular plan, and if they had a different product, such as an HMO versus a PPO, because the policy information was sometimes different there. And I want to note a few things as I talk through this. First, what we're highlighting is the potential for claim denials. We did not actually look at what happens to women who are using their insurance. So we don't know we didn't actually do an analysis of claims that are being denied, and that's important to know. And when we chose the specific exclusions, we chose 2 things we kept in mind is we did not want to include explicit violations of the law. So for example, if a plan were to exclude maternity services, we would not have included that because that's a very explicit violation of the Affordable Care Act requirement. Some of the violations some of the exclusions may be used in ways that violate the law, or someone may figure out does violate the law, but we didn't pick things that were very clear violations. The other piece is we wanted to stay away from some of the well-known exclusions that are important, but people are more likely to know about, and the 2 that I think of are things like exclusions for bariatric surgery and exclusions for fertility services. Not that those aren't important services, but those are things that I think gets covered more in the news and even within common understanding is a little more known. So the next slide starts an overview of our key findings. And what we found, every plan has exclusions. We knew this looking into them. Some of them are very broad. One of the broad exclusions we address is exclusions for maintenance care or maintenance therapies. Some of them are much more limited. Bariatric surgery and fetal reduction surgery are examples where what I mean by limited is they're specific to a service or a group of services that might be a little more clearly understandable. There are some that are extremely common. Almost every plan, if not every plan, excludes conditions resulting from an act of war. And then there are some that are really uncommon that, so there may be some exclusions that only one plan has or only a handful of plans have. So there's really a broad array of what you find when you start looking through these documents. And it's important to realize that these exclusions vary by issuer. So within a state, you may find that some issuers have one of the exclusions, others don't. Interestingly, there were on some exclusions you see very similar language across issuers, and I am not sure if that is from that language being part of the essential health benefits benchmark in a state that doesn't allow substitution, or that at some point those insurance companies plans had a relationship, or someone even used, the other company's documents, in first starting off. But there was sometimes language that was really, looked like it was cut and pasted between insurance plans. Exclusions can also, within an insurer, vary across states. So an insurance company might have an exclusion in one state that isn't in another. But by and large, we found these exclusions were pretty much throughout the plan that that insurer was offering on, on the exchange within any state we looked. And then also just that this report just provides a sample. There are pages and pages of exclusions in most plan documents. So we couldn't, in an issue brief, touch on all of them. So there are many more. The next slide provides just a quick overview, which I won't get into because this chart is in the issue brief, but these are the exclusions we talked about in detail. And I'm going to talk about the first two as well as fetal reduction surgery, since our other speakers will touch on the other two. So the next slide talks about conditions resulting from non-covered services. And I laughed because I did find a blog post criticizing this report, saying obviously insurance plans are going to exclude non-covered services, and but that's not what this is an exclusion for. This is an exclusion for conditions resulting from non-covered services. So I think if someone were to get, say, an elective rhinoplasty that they know is not covered, they probably would expect, and I think many of us would think it would be reasonable if it's not covered, that whatever the preparatory visits are, if there's medication they need in advance, any follow-up, routine follow-up, that generally probably wouldn't be covered because it's part of the service. But when you have conditions resulting from a non-covered service, that becomes much broader, and there isn't clarity in these informations about what is left. So will they deny if you get an infection from that surgery that results with you in the hospital? If a plan, plans right now, although this will be changing because of Section 1557, but many plans right now do exclude services for gender transition surgery. Will plans go so far if a transgender woman were to get breast cancer after starting estrogen therapy for her transition? Would they go so far as to say that that was a condition actually related to the taking of estrogen? And these may seem out there in some ways, but we also have to realize before the Affordable Care Act, these are things insurance companies did on a regular basis. Once one of the more egregious stories I had heard of under the pre-existing condition exclusions was someone whose cancer treatment was denied because the insurance company said a medication that person had taken as a child increases the chance of that cancer. So to hypothesize that these are the type of connections that insurance companies make really aren't out there. But these are really the issues that we're very concerned by, something that over 40% of the insurance plans we looked at had, and really raised the question, even if a service might be covered, but you go out of network, perhaps it wouldn't be, because you went out of network, would a complication be covered? And we just don't know. The next slide talks about the services to maintain rather than improve health. This is very common in rehabilitative therapy before the ACA required rehabilitative therapy. You could get physical therapy to improve, but once you no longer had improvement, people who had chronic conditions and needed ongoing physical or occupational therapy, often found that the plan would cut off coverage. But these exclusions are not specific to that type of therapy. Now habilitative therapy actually requires those types of services be covered. But because of the breadth of this, again, the real concern is that at a certain point, our insurers or might they start denying coverage really for treatment that we see as regular chronic disease management. The next slide talks about fetal reduction surgery. There was only one issuer that made an exception for medical necessity. So all the others, even in a case where the pregnancy or the mother's health or life is at risk, they might be excluded. And I'll note that, interestingly, every plan that had a fetal reduction exclusion had an abortion exclusion. The abortion exclusions will have to be in the summary of benefits and coverage, but not the mention of fetal reduction surgery. And someone may not, be enrolling in plans thinking that they're going to have a multiple pregnancy, or even if they have a multiple pregnancy, thinking they might be at risk. I am very quickly going to touch on the policy recommendations. They are, so the next slide, I won't go into a lot of detail because they are in the brief, but basically our policy recommendations were first for state regulators and federal regulators to look to limit exclusions through the essential health benefits process. And if people have questions about that, I would say, when we get to the question and answer, I'd be happy to get into more detail about these. And then the following slide, the last recommendations were really about increasing transparency. And really one of the most concerning things I felt with this was when a woman enrolls in coverage, she doesn't know these exclusions are there, and she doesn't even know to look for them. And so anything that marketplaces or regulators can do to increase the transparency should hopefully make the shopping experience better and reduce sort of gaps in care, because people will have a better idea of what they're buying before they buy. So I will pass it back to Janelle for our next speaker.
Thanks so much, Danya. And I just want to flag for folks, you will be able to ask your questions after all the presentations have concluded. So please keep in mind or jot down the questions that you have, because again, we want to allow plenty of time for detailed questions. And if you particularly want to focus your question on a particular panelist, you can indicate that as well once we start the Q&A. Next, we'll be hearing from Dr. Sue Friedman, who will discuss the impact of exclusions on women with high cancer risk. Dr. Friedman?
Thank you so much. It's really an honor to be here, and I appreciate the invitation. So I'm Executive Director of FORCE. FORCE stands for Facing Our Risk of Cancer Empowered, and our mission is to improve the lives of people and families affected by hereditary breast, ovarian, and related cancers. So that means many of the people in our community have either a very strong family history of cancers or have tested positive for a BRCA mutation or some of the newer genes that have been discovered. And so that's the community we serve. Next slide. So just as a really quick review, most people know about the provisions under the Patient Protection and Affordable Care Act, and especially for our community too, it improved access to a lot of services. It eliminated the pre-existing conditions, which were a barrier to care for many cancer survivors, coverage for certain screening and preventive services, which are do impact hereditary cancers and people at both average and high risk. The coverage of young adults, no lifetime caps, capping out-of-pocket expenses, and then another important one for our community, especially coverage for those enrolled in clinical trials. Next slide. But there have been some really apparent gaps that have happened after the Affordable Care Act was passed that we've been watching. And so one of the things that is interesting about the Affordable Care Act is that when they talk about covered preventive services, there's a reliance on the panel known as the United States Preventive Services Task Force, or the USPSTF, to guide which insurance, the preventive services that insurance companies are required to pay for with no out-of-pocket expense, no copay, no deductible to patients. And so there is a list on the United States Preventive Services Task Force website of the different areas of preventive medicine that they cover. In 2013, the USPSTF did issue guidelines specifically around BRCA, genetic counseling and testing for women with a family history of cancer, giving it a letter grade of B. Now, anything, again, in the Affordable Care Act, any preventive service with a letter grade of A or B must be covered. You know, soon after that, there was specific clarification issued by the Department of Labor that said this applied not just to the genetic test itself, but also the genetic counseling and testing, which was a positive thing because we know that people who see genetic counselors get more of an explanation about the test, the appropriate test is ordered, and they can adequately, you know, make sure that the test is being interpreted correctly. So that's really important. But even with this clarification, what we've seen and what we continue to see is that there are some plans that will not cover genetic counseling, and that's especially true in states that do not license genetic counselors and so therefore don't recognize them as service providers. Next slide. The other thing that happened is after the USPSTF issued their guidelines, one of the things that they did initially was they excluded these guidelines for coverage. When they talked about the population that was covered, they specifically excluded people who had previously been diagnosed with cancer. You know, that's their argument being that once you've been diagnosed with cancer, this is no longer a preventive service. You have a disease, and one of the things that we and other advocacy groups argued back was that, you know, there could be someone, for example, who had completed treatment for breast cancer and now wants genetic testing to find out if they're at high risk for ovarian cancer as well. So we really argued very strongly that this was a preventive service for some people, and because of that, in 2015, the Center for Consumer Information and Insurance Oversight, affectionately known as CCIIO, issued a clarification that extended the guidelines to women who had been previously diagnosed with cancer but were currently asymptomatic and no longer in treatment. So that's certainly not everybody, but it was an extension of these services, so that was a positive thing. Next slide. But, you know, one of the things that did end up being excluded was, and I apologize because I think I'm missing a slide here, but one of the things that was excluded was, in the letter grade, was the actual services at lower risk for someone who has been identified as being at high risk for a BRCA-related cancer. So the USPSTF issued guidelines that covered the genetic counseling and testing. And if someone ended up getting genetic counseling and testing and had a mutation, then there are national guidelines through the National Comprehensive Cancer Network and other national recognized guidelines that recommend you do something about that high risk, including, you know, increased breast screening, consider things like prophylactic mastectomy or risk-reducing mastectomy, and risk-reducing removal of the ovaries and fallopian tubes. Unfortunately, because the USPSTF did not issue a letter grade to those specific items, those services, they are not considered covered as a covered preventive service. And the argument that they gave for that when we did discuss this with the USPSTF was they called these things treatments rather than preventive services, even though they do have screening guidelines for average risk women, which I'll get to in a minute, and they even have guidelines for risk-reducing medication, what's known as chemoprevention, for certain high-risk women for breast cancer, but it's a very limited group and doesn't necessarily extend to people with BRCA mutation. So very confusing, not much continuity, and really the value of this particular preventive service, the genetic testing, lies in the ability to then go on to screen and detect cancer early or lower your risk with surgery or medication, and those are not considered included in the USPSTF guidelines with a letter grade. Next slide. So these current gaps in services for high-risk women, the USPSTF doesn't address increased screening and prevention options, like I just said, cancer survivors who are in treatment, genetic counseling and testing for other hereditary syndromes beyond BRCA. So Lynch syndrome is a colon, uterine, ovarian cancer syndrome caused by a different gene. There are other newer genes that are being identified that also increase the risk for many of these cancers, including breast and ovarian, that are detected in a different test known as multi-gene panel testing, and they're not covered. And a second test for women who previously tested negative because the technology has changed and improved over the years. And these newer tests can identify genes that were missed in the past. What's also problematic is, and this is really outside of the spirit of the law, is that some health plans are actually using the lack of USPSTF letter grades A or B as justification to exclude and deny any of these services for coverage. So they're not just saying, okay, you have to pay an out-of-pocket or you have to pay a copay. They're actually excluding it and citing the USPSTF lack of issuing a letter grade as the reason for exclusion. Next slide. So this was a slide I was missing before. Oh no, this is for average risk actually. So I'll just briefly talk about this. The USPSTF has separate guidelines for breast screening and mammography for average risk women. These were changed in 2009 and then recently updated, and those changes were held consistent. They recommended at that time raising the age for screening mammography to begin at age 50, which had previously been age 40, with a letter grade of B, and they recommend changing it from annual screening to biennial screening for women age 50 to 75, and other considerations starting younger, continuing after age 75, were given a letter grade of C. Next slide. Because of this, there was a national movement to kind of stop the guidelines and issue a moratorium with the concern that there would be women who would not be able to get access to these services. And so this led to the passage of something called the PALS Act, which actually made sure that recommendations for screening or coverage for screening had to roll back to the 2009 recommendations, which were for women who starting at age 40 and annually, with the idea that many women are not aware of their increased risk. Some of the women who are not who were not included in the research that led to the change in the guidelines were women who are at high risk for more aggressive cancers. This includes African American women. It includes women with a mutation who may not know that they have a BRCA mutation or other gene mutation that puts them at high risk. Waiting till 50 could lead to missed cancers, more treatment, more aggressive cancers, and early death. Next slide. I'm actually going to skip the Medicaid and Medicare, just briefly. Medicaid, about half the states have guidelines for or cover genetic testing, and Medicare also has a lot of gaps, including it doesn't cover any genetic testing for women who have never had cancer, so people who are high risk. And then in some regions, they just started expanding it to people with pancreatic cancer and multi-gene panel testing. Next slide. So, you know, the consequences for women of these service gaps are that they're deprived of the opportunity to receive genetic counseling with a certified genetic counselor, which we've found to be very important as far as making sure that they're getting up-to-date information, and that their tests are being accurately interpreted. Many women are unable to access genetic testing and important information about their risk. They're being denied coverage of evidence-based recommended preventive services, and are faced with substantial out-of-pocket expenses year after year to get access to these services. Next slide. And this puts them at risk for financial toxicity, foregoing some of the standard of care preventive detection and preventive services, potential for need for more treatment because their cancer was diagnosed at an advanced age, impact on relatives, and then early death from a cancer that may have been preventable otherwise. Next slide. So just quickly a few suggestions for addressing these gaps. Changing the constitution of the USPSTF panel, and who sits on the panel. It's mostly public health experts, but they don't have oncologists on the panel. There are no patient representatives on the panel. May change how they address these issues. Expansion of the Affordable Care Act to include other expert consensus guidelines, not just the USPSTF guidelines, so for example NCCN. Changes in laws dictating which insurance companies, which services insurance companies can exclude, better awareness and enforcement of the laws, and coverage of genetic counseling. And I'll stop with that. I'm sorry I went over.
No problem.
Sorry.
Thanks so much. This is great information. And again, I'll request that folks hold their questions until our final panelist has concluded, and then we will start the Q&A time period. And next we'll have Tim Clement, who will discuss the impact of mental health exclusions on women. And Mr. Clement.
Yes, thank you. Thank you very much. And Janelle, can you hear me? Is my voice coming through?
Yes.
Okay, great. Well, thank you. It's an honor and a privilege to be part of this webinar. My project is Parity Track. I'm the policy director, and Parity Track is a project that tracks implementation of the federal Mental Health Parity and Addiction Equity Act of 2008. Parity Track, of course, is led by former U.S. Representative Patrick Kennedy, who was the lead sponsor of the Mental Health Parity and Addiction Equity Act. I also am the lead policy person for all of Patrick's other behavioral health policy issues. So what I'm going to be talking about today are benefit exclusions related to mental health care that disproportionately affect women. One of them is going to be exclusions for self-inflicted injuries. Another is going to be exclusions for treatment of eating disorders. Then I'm just going to briefly talk about a de facto exclusion, which comes in the form of aggressive medical management practices. Next slide, please. Exclusions for self-inflicted injuries. So these are exclusions that involve treatment of injuries largely resulting from suicide attempts among people with depression and, of course, other conditions. The historical context behind these exclusions are that traditionally people with mental illnesses and people who attempted suicide have faced great discrimination and stigma, and so suicide attempts are often seen as a form of moral failure or a selfish act rather than the tragic course of events of a medical condition like depression. And one reason this is included in this webinar is that women are disproportionately affected by this because women have higher rates of depression than men, higher rates of non-fatal self-harm, and higher rates of suicide attempts, and also higher rates of suicide attempt survival rates due to the fact that men more frequently use firearms as a method to attempt suicide. So because of that, more often than not, when a person experiences an exclusion because of self-inflicted injury, that person is in fact a woman. And one thing to keep in mind is that plans often do not define self-inflicted injuries, and sometimes they may refer to them as intentional self-inflicted injuries. And this gives plans broad leeway to exclude various injuries. And the technical term for self-inflicted exclusions are source of injury exclusions. Some other examples include exclusions for injuries sustained while in the commission of a felony, injuries sustained while operating a motor vehicle while driving intoxicated, And there's some other, but self-inflicted injury exclusions are less common than they used to be, but they are still a significant issue. Next slide, please. Okay, so I'm going to talk a little bit about the role of mental health parity and how that relates or does not relate to these exclusions, and also our other exclusions. So the Federal Mental Health Parity and Addiction Equity Act, and I'll simply refer to that as the federal parity law from now on, requires coverage for behavioral health benefits, that's of course mental health and addiction coverage benefits, to be no more restrictive than coverage for other medical benefits. And part of being no more restrictive means that exclusions that are placed on behavioral health benefits cannot be used if they are not also put in place for medical benefits. So for instance, if a plan has an exclusion for, says that behavioral health, they will not cover a behavioral health treatment facility outside of the state, if that same exclusion is not in place for medical care, then that exclusion is forbidden and illegal. So that leads us to the question of what is the role of mental health parity, the federal parity law, on these exclusions for self-inflicted injuries. And the first question we have to answer are exclusions for self-inflicted injuries behavioral health exclusions, or are they medical benefit exclusions? Next slide, please. So this is actually, what we find is this is actually not covered by the federal parity law, because technically speaking, exclusions for self-inflicted injuries and their treatment are medical and surgical benefits, not behavioral health benefits. So the federal parity law says that behavioral health benefits have to be equivalent to and applied no more stringently than medical and surgical benefits. But in this instance, even though this is something that is the result of a behavioral health condition, the actual treatment itself is medical and surgical. So in this instance, the federal parity law is not relevant. And the Department of Labor, the Federal Department of Labor, has issued statements to the effect of saying that is how they interpret it. However, the good news is another federal law, the Health Insurance Portability and Accountability Act, commonly known as HIPAA, and the regulations issued pursuant to HIPAA in 2006 prohibit plans from imposing exclusions for self-inflicted injuries if they are the result of an underlying medical condition like depression or any other condition like bipolar disorder or borderline personality disorder, schizophrenia, whatever it may be. So if there is in fact an underlying medical condition associated or an underlying mental health condition such as depression, which is often the case with a suicide attempt or almost always the case, and other forms of self-harm, then it is illegal for plans to impose these exclusions. However, it is critically important, and this is sometimes why these exclusions still stand, that there must be a diagnostic code with that treatment that indicates the treatment of the self-inflicted injury was the result of an underlying condition such as depression. So without that code, the plan can still legally deny those benefits. Next slide, please. So another exclusion that significantly disproportionately affects women are exclusions for the treatment of eating disorders. And these are still very common. And of course, eating disorders are much more prevalent among women than they are among men. So one thing that is less common now but still does take place is that sometimes plans will entirely exclude coverage of eating disorders. It'll just be an excluded benefit. And in some states that is actually perfectly legal because one of the weaknesses of the federal parity law is that it does not define mental illnesses and substance use disorders and leaves that to the states. So if you live in a state that has an antiquated definition of mental illness that does not include eating disorders, then the plan may exclude those benefits for eating disorders. That is much less common. What is much more common is that plans will exclude coverage of residential treatment for mental health conditions, which is often a medically necessary form of treatment for women affected by eating disorders, and it's most frequently used for women with very serious forms of eating disorders. And there are a number of plans will frequently completely exclude residential treatment, and this is covered by the federal parity law, and in most instances completely illegal. If a plan covers subacute inpatient care, such as medical care in a skilled nursing facility or care or hospice care for medical conditions, it cannot exclude residential treatment. So that is an instance where the federal parity law does come into play. Next slide, please. So the one thing I want to talk about that is not an actual exclusion as written in a policy, but oftentimes becomes an exclusion in practice, is the aggressive use of managed care. One thing that plans have been doing more and more frequently in the last 2 decades, and particularly related to behavioral health benefits, they employ very aggressive medical management techniques that effectively exclude inpatient care for depression and eating disorders, among other conditions. But those are two of the conditions where we see inpatient care, particularly residential treatment, being excluded in practice, not in theory. So the summary of benefits might say that residential treatment is provided. But what plans will do is they will employ these medical management practices. So for instance, one of the most common ones is plans will review a claim to determine if they'll approve it, to determine if it's medically necessary. They're called medical necessity reviews. And so they will put in place these medical necessity reviews, and what we'll often find is that they will deny residential treatment for depression and especially eating disorders on the grounds of it not being medically necessary, even though these denials are almost always contrary to the clinical opinion of attending providers who know the patients, know their families, know their home conditions, and know that residential treatment is probably in their best course of treatment. So in effect, what happens, and what we see is these denials, in some instances, come in at a rate of 100%. So that a plan will never approve residential treatment as being medically necessary. So even though the plan says that this coverage, this benefit is available, in practice and in operation, it actually is not available. And this certainly does violate the federal parity law in the sense that how plans design and apply these medical management practices to behavioral benefits have to be comparable to and applied no more stringently than how they apply these medical management techniques to other medical care. And what we know is they're applying these much more stringently for behavioral health care. And the problem we've had so far is that enforcement of the federal parity law has been lax to date by state and federal regulators. So that is something that until the plans are sanctioned for doing this in a significant way, we are going to continue to see this aggressive form of medical management that is not in compliance with the federal parity law. Next slide, please. So some policy recommendations. One, for self-inflicted injuries exclusions, state laws can simply prohibit plans from doing this. Minnesota is a state that prohibits plans from excluding treatment for injuries sustained during a suicide attempt. Federal and state regulators can issue sub-regulatory guidance, such as letters or bulletins to plans reminding them that self-inflicted injury exclusions are prohibited under HIPAA if they are a result of a medical condition. While they shouldn't need to be reminded, sometimes that kind of reminding does in fact lead to action. And then in terms of residential treatment, state legislators can amend laws that eating disorders are explicitly included within state definitions of mental health conditions. That is something that a number of state legislatures have done in the last 10 to 15 years. And then state and federal regulators should ensure that medical management practices for behavioral health benefits and other benefits are designed and applied comparably as required by the federal parity law. As I hinted at earlier, this is a federal law that's been in place for nearly a decade, and only now are we starting to see the beginning signs of enforcement. So that's something that we need to see continued improvement in this, and thankfully there is a current White House parity task force designed to help improve implementation of this law, and their recommendations are due out in October. So we're hopeful that we're going to be seeing some big changes in 2017. Next slide, please. Okay, that's all I have. So if any additional questions or comments about these issues or anything related to behavioral health insurance coverage, please contact me at tim@paritytrack.org. Okay, Janelle?
Thanks so much, Tim, and thank you to all the presenters for this very helpful information. And as you can see, everyone's contact information is listed on the slide that's showing now, so that if you have additional questions that we are not able to address during the short time, we have about 15 minutes for questions right now, but if you want to follow up directly with the expert about a very specific issue, you can weigh in and reach out to them at that time. At this time, if you can input any questions that you might have, and we will take a look at those questions and ensure that we can try to address as many of those as we can. Okay.
And just just a reminder to the whole group, as questions are rolling in, that we have recorded this webinar, and so we will circulate a link to the webinar recording as well as the slides and any additional resources within the next couple days, so please just check your inboxes for that. And then you should be able to share that link with any colleagues or other folks who may not have been able to join but are interested in the content.
Thanks, Amanda. One question that we do have, and I'll put this out broadly to the panelists, is there information about coverage of substance abuse disorders, particularly for pregnant women?
So this is Danya. I'll let the others start.
Danya, please go ahead if you're going to answer.
I was going to say, we did not notice anything in our review specific to that. Under mental health parity, substance abuse is required to be covered in parity with other services, and my understanding is many of the issues Tim talked about apply in both substance abuse and mental health, and they are problematic. But substance abuse has traditionally not been considered covered under maternity care. So it's sort of, as it interacts with pregnant women, it would be sort of the care a woman's getting as she's pregnant along with whatever the insurance plan is doing towards substance abuse. And Tim, you probably have things to add.
Yeah, so thanks for adding that. I think that, yes, the mental health and addiction parity law, it certainly does cover substance use disorders. And one thing that is where we're finding some of the greatest disparities is that individuals and women with substance use disorders are not getting adequate care and are facing very restrictive denials for needed coverage, particularly, as I mentioned, for residential treatment. That is a huge issue on the substance use disorder side. Residential treatment is very frequently denied as being not medically necessary when we know that it often is. And I know that there's language, if you'd like to follow up with me on an email about that, whoever asked that question, there's actually language in one of the federal mental health bills, mental health and substance use disorder bills that's out there right now that specifically addresses maternity care for women affected by substance use disorders. So if you want to email me, I'd be happy to sort of patch you in with that language.
Thanks so much. And anyone who has any additional questions, please feel free to input those questions, and we will hopefully address them while everyone is online. And since we don't have any additional questions at this time, I will just ask for the presenters, what do you advise a woman to do if she has a claim denied because the insurance company says that the particular service is excluded or not covered by the plan? And Donnie, I know you mentioned in the opening that your focus wasn't on actual denials, but what should a woman do if her plan specifically excludes one of these services that is discussed in the report?
The first thing is, don't just take it and pay the bill and forget about it. It is important to appeal. Even services that are specifically excluded from the plan, there are instances when an insurance company will cover it on an appeal. I actually do have a friend whose insurance denied coverage for genetic testing, prenatal genetic testing, when she had the unfortunate history of having already had a child that had a fatal genetic birth defect that they were able to, if they knew to look, could pre-diagnose. And she did appeal it, and I believe the insurance company did end up paying for it because they were able to show medical necessity, because she and her husband sort of carried this increased risk. So there are times when an appeal actually can get something covered that even if it initially wouldn't get covered. It's important to be educated, though, about the appeal process, and for anybody working with consumers, letting them know they need to know what the time frame is to do an appeal. They should also find out that there's a process for appeals for pre-authorizations that are denied, and if not, they should still find a way to fight and to push for that pre-authorization to be approved if that's when it's denied. and to find out the exact reasons and work with their providers to get the medical necessity information. And if there is anything that an individual believes is actually a violates the law, is discriminatory, violates parity, that should be reported to regulators. And so anything that is discrimination in health insurance can go to reported to the Office of Civil Rights at HHS. I am sure sex discrimination at the National Women's Law Center would love to hear about it. Not that they want it happening, but would be asked. But I'm sure they'd be affected. But the same reporting mental health parity violations, and if it's an employer plan, to make sure that's reported to the Department of Labor, and also, if it's also the state insurance regulators, if it's a state-regulated plan, that complaints need to be filed because that's the only way regulators will know if plans are actually doing things that are illegal. And and if people have the ability to go through the entire appeals process, it takes time, but you may find that in the end you do actually get your service covered.
Thanks so much, Danya.
Hi, this is Sue. I think that's excellent, excellent resources. And in addition, when we're talking specifically about hereditary cancer risk, FORCE actually has sample appeal letters for genetic counseling, genetic testing, panel testing, and then some of the preventive services, as well as guidance on how people can access that. I think another good resource in addition to the insurance regulators' offices is the CCIIO. They have a helpline, the Center for Consumer Information and Insurance Oversight, and it's my understanding that that's the agency responsible for enforcing the Affordable Care Act. I could be really wrong though, but I'm happy to provide that information, which was provided to us and we have on our website. The one other thing, there was one other thing I wanted to add with regard specifically to genetic testing for cancer risk, is that if at the end of the road insurance still won't pay, there are options for low-cost testing. A lot of the labs also offer support for testing, so there are other resources where people can access services even if their insurance won't cover it and not have too large out-of-pocket costs.
Thanks so much, and I was going to confirm, I do believe that's correct. CCIO, or the Center for Consumer Information and Insurance Oversight, does have some information. Honestly, their website's a little bit difficult to navigate, but if you access their website, they do have some information, and they do provide some review for certain health insurance plans, and I believe that more specific information is detailed on the website. And we'll be happy to send out a link as well, so that folks have that information too. But again, I'm not sure how broadly they cover in assisting with appeals, but we will be sure to forward that information. And I think a final question, and again, we encourage folks to type in your questions. We have about 5 minutes left. Let's see. It looks like we do have an additional question. What is your recommendation for women who have been denied coverage for medically necessary breast implant removal?
So this is Danya. I will start. I will first note that if the breast implants were at all related to cancer treatment, and that the Women's Cancer Rights Act may apply. I may have those words a little out of order. So it would be important to look into that piece of it. Otherwise, you may be, there may be situations where what they are dealing with is that exclusion or complications related to non-covered services. If it is a I will note if it's a condition that existed before they enrolled in the plan, it never hurts to try to approach the appeal noting that it was a pre-existing condition and can't be denied. But besides that, it's really, I think, working with the provider and calling the insurance and trying to find out. Sometimes there are people with the insurance plans who are willing to give you a little more information if you get the right person on the phone, and also talking to the providers, because your provider, woman's provider, particularly the surgeon and the people in the surgeon's office, may know what type of diagnostic codes to put down to get it covered. That is one of those things I will say that happens. Providers know that if the providers are more likely to be providing services that are generally covered by insurance and providing that service regularly. So, I mean, if it's a doctor that doesn't, you know, if for some reason the individual is in a small rural area and there aren't a lot of providers, and the providers that use it, they might not know as much about what the best diagnostic codes are to use to get the insurance coverage as, you know, a doctor who's doing this on a much more regular basis. Unfortunately, though, I will note if it was purely cosmetic complication, you know, a purely voluntary cosmetic surgery and not related to the cancer which is required, or if it's also related to gender reassignment surgery, as Section 1557 non-discrimination starts becoming getting implemented and more of a reality in our insurance than it is now, it may be covered under that piece as well if the original breast implants were part of gender reassignment. But if it truly was a service that's not covered, it can be very difficult, and I would recommend fighting it and trying to find all the links, and maybe even with anything, I mean, sometimes there are a lot of patient groups out online that may have a variety of different information, but you might find someone who has shared their successful appeal letter or something along those lines. And I don't think it necessarily hurts to try that type of thing, of seeing what other people have if you're not able to find providers or advocates who have the specific information to help your situation.
Thanks so much, Danya. And we do have a quick question just asking for more information about the role of the Center for Consumer Information in Insurance Oversight. And I can say briefly that the center is tasked with helping to implement many reforms that were included in the ACA, particularly overseeing the provisions related to private health insurance. And CISIO, which is the acronym there, works close with state regulators and consumers and other stakeholders. And if you go to cms.gov online, you can do a search for CISIO, and they have a section on their website to the left for consumer support and information that has a little bit, if you click on that, it has a little bit more detailed information about issues with health insurance. Particularly, they have a section called External Appeals, which relates to private health insurance. And I know that's a very brief overview as we're short on time, but we would be happy to send out a link to, again, the Center for Consumer Information in Insurance Oversight. And I don't know if any of the panelists wanted to add anything about the role of CISIO.
And this is Danya. I would just say that for the most immediate reaction, if there is, that the state insurance departments are often quicker at moving and working with insurance companies, and CISIO will often expect people to have got, or will direct people to that process. Often, CISIO is very important, though. If there is a plan that you happen to see on a federal facilitated marketplace violating the law, it's very important that CISIO knows, because they have that ability to take action against that plan directly related to their offering on the exchange. But I've seen even in states that say they're not enforcing the market reforms, well, they may not be reviewing them. We have heard some instances of women who have still gotten their situation addressed by going through the insurance commissioner, and the insurance commissioner still has, notified the insurance company when the plan was in violation of the law, particularly when it's very explicit violations.
Yeah, and this is Tim. I just wanted to chime in. One thing just to note for everyone on the call related to insurance coverage is that don't forget about the Department of Labor, because they are responsible for regulating all self-insured commercial plans, and that is actually a very significant number of plans out there. So just whenever we're thinking about insurance, be sure to not forget about them, because obviously, marketplace plans are not under the purview of the Department of Labor, but a very significant portion of the insurance plans out there are regulated with the Department of Labor. So just make sure to be aware of that.
Thanks so much. And I think we will close out at this time. If there are no additional questions, as we are 1 minute over right now. But thank you all so much for calling in, logging on to today's webinar. And again, as you can see, we have the panelist information. This webinar has been recorded, so it will be accessible if you want to review at a later time. And again, we also encourage you to read the full report that's available on the National Women's Law Center's website, nwlc.org, that was supported by the Commonwealth Fund. And thank you so much.